Okay, that's the numbers have creeped up nicely, so I suggest we make a start. And yeah, welcome everybody to today's webinar. I'm Darren Morgan. I'm the Engagement Director at the Economic Statistics Centre of Excellence. And welcome to today's seminar. It should be a really good one. The topic is so interesting. It's on the treatment of preventative medicine in the national accounts, and we're using diabetes as a case study for that. And it's a super interesting topic and important, I think, because its research, I think, has far-reaching applications. So so it should be a good topic to discuss. And we have two brilliant speakers involved. We have Martin Weale from the King's College London, who will be presenting, and we have Robert Inkler from the University of Groningen, who will be out discussing. So really good two people to set the scene for us all. For those who haven't been to one of our webinars previously, why not? But just in case you haven't, the structure is Martin will speak for about 40 minutes, then Robert will respond in around 10 minutes, and then we have 10 minutes for questions. So when you do have a question, there's a Q&A panel there that you can place your question, but we'll unmute the mics at that point. So if you would like to join the call to answer your question, you're very welcome to. But if not, Martin will respond, or Robert or myself will handle the questions on your behalf. So I suggest we get started, is it? Martin, over to you.
Well, thank you very much for that introduction, and thank you for giving me the opportunity to. Sorry, have I lost the sharing?
No, sorry. Martin, no, it was fine. We lost it now.
Yes, I'm sorry, it'll come back.
Okay.
Okay, so sorry about that delay. It's a while since I've done sharing on Teams and actually clicked on screens and so on, but so my apologies for that. So what was the motivation for this work? Well, I think it came from two directions. First of all, I think there's a general view that economic statistics don't adequately represent well-being and some of the things that influence well-being, such as the outcomes of health spending. And that raises particular concerns about how you manage preventative treatment. How should the national accounts account for something that doesn't happen rather than something that does happen? Jeremy Hunt, the previous Chancellor of the Exchequer, was particularly concerned about this. So in some sense, at least before the general election, the time was right to be looking at it. And while I don't know what the current Chancellor's views on the matter are, it's certainly something that is important for ESCoE, is important for the national accounts, and particularly so given that the 2025 system of national accounts wants to have more of a focus on well-being than used to be the case. How far that's practical is, of course, a separate issue, but that's the goal of the 2025 system of national accounts. So in this paper, I explore the treatment of new services in the national accounts. And what I do is set out a framework for managing the introduction of new services whose benefits may be several times their costs. By benefits, I mean taking account of their benefits in terms of patient well-being, in terms of expected life years, adjusted for the quality of life. So looking at non-financial measures as well as financial measures. Now, it's all very well to have a plan for the treatment of new medical services, but you need to be sure that it's consistent with what the national accountants do already, or produce very good reasons why it shouldn't be. And in particular, if we replace an old medical service with a new medical service, that can be seen like, or that could reduce to a change in quality. We have an existing framework for managing changes in quality. And so what I show in the paper, although not on screen, is that the treatment that I'm proposing is for an increase in quality consistent with withdrawing a low quality service and replacing it with a high quality service. it's also consistent with withdrawing an expensive service and replacing it with a cheaper service, i.e. a straightforward price reduction. So the framework is consistent with what goes on at the moment, at least provided you can produce the right index numbers. And I then get on to the particular question of preventative public health measures, which can be applied to the diabetes prevention programme. That's a scheme intended to stop people or to reduce the risks of diabetes rather than to treat diabetes once people have developed it. What I actually show is that perhaps contrary to intuition, the effects of the programme on the gross output of medical services are relatively small, and if you measure them in terms of the extra life years that perhaps medical services deliver already, they become even smaller than if you measure them in the context of the National Accounting Framework. So if people did have the intuition that preventative medicine always had large impacts, I think in this case that's not true, but of course there may be other preventative treatments for which that is true, and in particular, of course, this framework may be useful for looking at the effects of weight loss drugs, at least if there are estimates of their implications in the longer term. What are the problems with medical treatment? Well, beneficial medical treatment may be resource saving or resource using. So, for example, in the 1950s, the NHS benefited from resource saving medical treatment. Instead of needing tuberculosis hospitals that weren't terribly effective, you could replace them by cheap drugs that actually cured people. Now, on the other hand, expensive drugs and treatments tend to add to costs. Then there's the point that I've been making already, that the value of life years can't satisfactorily be represented in the existing national accounts. So one framework is to develop a satellite account. Cutler and colleagues did that for the United States, and they were able to suggest substantial increases in the productivity of the health service, measuring its output in terms of quality adjusted life years. Now, those quality adjusted life years, you can produce an account in those terms, but Paul Schreier more than 10 years ago suggested that they should be used as a quality measure of existing health services. So if you replace a service that generates X QALYs by one which generates more QALYs, that's an improvement in quality, and the 2008 SNA says that should be treated as an improvement in output. The 2010 European System of Accounts, on the other hand, is keen that you should measure improvements in quality of services in the private sector, but not in the public sector for reasons that aren't clear. Anyway, Britain is now no longer bound by the European System of Accounts, and I think, well, I more than think the ONS does intend to make sure that quality adjustments can be introduced to measures of the health service. So those are issues. One point I would mention about Paul Schreier's approach is that because he weights the outputs of the individual services by shares in costs, or implicitly shares in expenditure, the answer that you would get from his approach would depend on the core categories, the way in which you aggregate the individual components. And you might therefore say only apply it in aggregate, in which case you would get the same result as Cutler's adjustment, at least for gross health services output. What about a new service? Well, this is an issue that has been around for a long time. Fisher and Shell wrote about it in 1972. They distinguish an output price index from a cost of living index. The first is looking at supply conditions. The second is looking at demand conditions. They were able to get clearer results in the second case than in the first case, but essentially the practical message that comes from their work is to calculate a price index with the assumption that the service was priced at its reservation price, i.e. the price at which demand would just be zero in the period before the introduction. Now, if you have a Laspers index, you would base your weight on the situation when the expenditure share was zero, and if you have a Laspers index, this approach then wouldn't satisfactorily introduce the new good or service. If you have a Parsh index, you'll give a full weight to the period when the service was introduced, and that's likely to overstate its impact because you're essentially saying that people have been spending money on the service throughout the period for which you produce the Parsh index. I've looked at a Turnquist index, weighting the change in price from the previous period by the average of expenditure shares in the previous and current periods, but you could also use a Fisher ideal index, and I think they would probably give similar results. Anyway, having calculated the impact of this new service on the price index with the Turnquist index, it's quite easy to calculate a volume measure from value data and the price index. Now, stressing the point I made earlier, a quality adjustment, quality improvement can be seen as replacement of low quality by high quality, or if you use an index of quality in the way Paul Schreier suggested, it can be represented as a price reduction and therefore with spending unchanged as a volume increase. And the two methods, whether you look at it as a quality adjustment or a replacement of one good by another, give the same results if the withdrawn service is assumed to have a reservation price reflecting its low quality. So in the period in which the withdrawn service has disappeared, we represent the price of that falling to the point at which it's just competitive with the new service, but only just so demand for it is still zero. And if you do that, then symmetric indices record the same increase in output with both approaches, and even more simply, you can show that you can represent a straight fall in prices through that route. So actually, if we think of something that, particularly of something preventative, there are two possible reservation prices. The first is based on discounted cost savings, and the second is based on the discounted quality adjusted life years gain. Now, health policy is based on quality adjusted life years, at least that seems to be what the National Institute of Clinical Excellence says it does, so it's more natural to use the money value of discounted QALY gains less the discounted costs of future treatment of those exposed to the public health measure as the reservation price. So let's put that in an algebraic framework. Here I've got a disease that if you don't catch it, you get QN discounted per capita QALYs. If you do catch it, you get QT discounted per capita QALYs. Rho is the risk of the disease without the public health measure. Rho H is the risk of the disease with the public health measure. N is the relevant population, and C is the discounted cost of treatment. H is the cost of the public health measure. So if we don't have the public health measure, 1 minus rho times QN get the QN QALYs. They're not affected by it. Those who are treated, who are ill and treated, it's a fraction rho of the population, get QT QALYs, and the cost of that to the public is rho times the cost of treatment per patient. With the public health measure in place, we hope that rho falls to rho H, so more people get QN, the QALYs of the unadjusted population. The cost of that, well, the public health measure has cost something, so they face a cost of that per capita. For the people who need treating despite the public health measure, Rho H is the probability of incurring the disease. C is still the cost of treatment, but actually the cost for this subgroup of the population has risen because they also have to pay their share of the unsuccessful public health intervention. No, we can calculate the reservation price based on costs or the reservation price based on QALYs. The reservation price based on costs is rho minus rho H, this is the total reservation cost, rho minus rho H times C for one patient, rho minus rho H times NC for the full patient. The reservation price based on QALYs turns out to be Q, little q, where Q is the value of a QALY, multiplied by the population, multiplied by the difference between the QALYs of the untreated and treated populations, and by the difference in risks. And you can show that the QALY reservation price is larger than the cost reservation price if the condition set out in equation 1 holds. So if that does hold, and it's likely to hold, if we use QALY data, we'll get a larger reduction in price on the introduction of the program. And if we get a larger reduction in price, that's likely to reflect a larger increase in the volume of output than would be the case if we base the calculation solely on costs. I should say here that another area where people have used this approach is looking at the introduction of social media that are free or almost free at the point of use, and they similarly don't base reservation prices on costs. They base reservation prices on estimates of the amount people are likely to need to be paid to give up using the service. Anyway, if we want to look at what this does to prices and quantities in the first year, we want to measure with reference to a situation without the public health measure in place. Or if you're looking at a change over time, you can think of that as being the situation in the previous year. So the change in the implied price is the share of extra expenditure with the public health measure, H over M plus H, where M is consumption of medical services excluding the public health measure. From that you can apply the Turnquist formula and get the change in price. The change in the volume of output is then, or the change in the log of the volume of output is then the change in the log of price with the public health measure introduced, less the change in the log of price shown by equation 2. That's quite a straightforward calculation. In subsequent years, we need to think again about the situation without the public health measure in place. If C-TOR is the cost of treatment TOR years into the disease, in subsequent years there's a saving of C-TOR multiplied by the reduced risk of contracting the disease, with no changes in prices, no new goods introduced. This is a straightforward reduction in the volume of output. Now, you might say this is a good thing leading to a reduction in GDP or NDP, but I think that's quite the wrong way of saying it, or the wrong way of seeing it. If you have a reduction in the need for medical services because of the public health measure, you can move from spending things on medical services to spending money on the sort of things that people actually want. Going to the doctor, being treated, is something that people would probably prefer to do without, whereas things like holidays, warm houses and so on are things that they want to spend their money on. But since we're looking at an output price index, not a cost of living index, we're looking at the production side rather than the demand side. This increase in welfare from the change in the composition of output isn't reflected in any of the national accounting indicators. The national accounting indicators don't show the welfare gains from a reduced need for medical treatment. Now, I've been sort of talking about a single cohort. You introduce a new treatment which can treat people. In practice, there's a population sequence that though you have old people who eventually die, you have young people who need replacing, who replace them, and in a steady state, you'll need to repeat the public health measure for each new cohort, but that won't represent an increase in output. It'll be simply sustaining the new higher level of output. Now, because the world isn't as simple as that, some judgment will be needed on what counts as the introduction of a new service and what is simply a continuation of an existing service. And that becomes all the more important because different cohorts are of different sizes. Now, actually, as far as I can see, we should treat reductions in the need for medical treatment in much the same way as we might want to treat reductions in the cost of living arising from reduced risks associated with the things you insure yourselves, people insure themselves against. Here, the Consumer Price Index and CPIH, no, don't provide that treatment. The HCI, the Household Cost Index, treats the price of insurance as a cost of a policy, so changes in that would reflect changes in welfare from reduced insurance costs, and extending that principle to the public sector as well, we could perhaps start to look at changes in the demand for medical services leading to increases in welfare. But it's not quite clear where you ought to apply that. I suppose what my thought is that we might want to try and apply that principle to insurable risks, whether people actually buy insurance or not. And insurable risks plainly include medical services as well as the risks of loss or damage to property. Anyway, how might that work in practice? Look at it through the lens of the cost of living index described by Conius. So utility is a function of consumption, and D is an indicator which takes a value 0 if you don't have a disease and 1 if you do have a disease. So we can say that utility of C0 for a healthy person is the same as the utility from a much or a materially higher level of consumption for someone affected by a disease. And here C1 over C0 measures the cost of living for someone affected by the disease relative to someone who isn't. C1 minus C0 measures the cost of treatment plus the extra consumption you need to that's needed to compensate patients for the disutility of the disease. The expected cost of living with rho the risk of contracting the disease is then rho C1 and 1 minus rho C0. With the public health measure in place, that changes to rho HC1 plus 1 minus rho HC0 plus H over N, where H over N is the cost per capita of the public health measure. So we can now calculate the cost of living index with the public health policy in place relative to the situation where the public health policy isn't in place. And you can see that provided the impact on rho H relative to rho is large enough, the cost of living will fall on the introduction of the public health measure, even though the public health measure has to be paid for. This resolves the insurance problem. It's easy to do in a one-off case, but I'm not sure how it would work in a situation where the disease was expected to persist. No, there you would have to look at expected future lifetime utility rather than just utility in one period, and how to put the, worrying about how to put the pieces together makes my brain hurt. The alternative is to look at a satellite account of the sort that Cutler had proposed. There, the discounted QALY gain is given from the QALY reservation price. Now, it's easy enough to say what the extra QALYs are. What's less clear is what you should measure that as a percentage of. Cutler, in his lengthy study, devotes one paragraph to saying he's assumed that medical services generate half of the expected discounted QALYs accruing to 65-year-olds in 1999, and that gives an estimate of the gross output of health services in the United States. Half is somewhere between 1 and 0, so perhaps that's a good reason for choosing it, but the impact of any new service that you get in percentage terms will depend on the denominator, and I don't think there's any clear way of defining the denominator if you want to produce a satellite account. Anyway, what about diabetes? As many of you will know, it's a chronic inability to control blood sugar levels. It results in wounds being slow to heal, creating risks of amputation. It also carries risks of heart disease, kidney disease, stroke, eye disease. Excess weight is thought to be a major factor. The prevalence of diagnosed diabetics has risen from 2% in 1990 to 6% in 2021, with a sharp increase also among those 75 and over. How far that's because diabetics are living longer, how far it's because hazard factors have increased isn't clear. Here I've said that rising weight of the population is probably more important, but it does actually depend what you read. Some people argue that actually the incidence, the risk of developing diabetes by age hasn't been going up for a while, and that the higher prevalence is simply because people with diabetes are living longer than they used to. A recent study earlier this year put the cost of diagnosis and management at 3.2 billion, the treatment of complications at 5.6 billion. There are 4 million people who have type 2 diabetes, and there are thought to be 1.2 million people who haven't been diagnosed but have it, and that's presumably based on doing blood tests on people who turn up for other things at doctors' surgeries. Anyway, that implies an average cost of 800 for diagnosis and management, 1,400 for these are per annum for treatment of complications, but the complications are more likely at a later stage. A detailed study in the Irish Republic put annual costs at about £850 with no complications, and then rising sharply in the nature of the complications. Anyway, a training program was introduced in 2017 with 15 classes offered to people who are so-called pre-diabetic. That's with blood sugar in a range which is higher than normal, but below the level at which the WHO recommends as the definition of diabetes. The ONS suggests that 1 in 9 English adults is pre-diabetic, grossing up for the whole country. That gives 5.8 million people. The programme encourages weight loss and regular exercise. It also offers dietary advice. So it's designed to encourage healthier living. And there is increasing evidence that diabetes itself can be put in remission by weight loss, at least for people who have diabetes and are overweight or obese. A pilot scheme was run for the prevention programme in 2017, and it was assumed by the NHS that 4.5 cases per 100 participants would be delayed or avoided as a result of the programme. This was based on similar programmes elsewhere. A Finnish study suggested 7.4 cases per 100 participants, but some people have argued that there are selection effects and there's no significant impact from the programme. While you can do randomised controlled trials on who's referred to the programme and who isn't, you can't force some people to continue to the end of the trial and force others to give up. So it's not possible to do a proper randomised controlled trial to look at the effects of the programme. What are the key programme statistics? Well, if we start with 1,000 people referred, 530 people attended an initial assessment, 340 people attended at least one session, 180 completed a course. Of the 1,000 referrals, 127 were diabetic 3 years later, but that rises to 154 for comparable GP lists who weren't referred to the course. So on that basis, the course seems to have some impact, but I think it also has to be said that it seems to me unlikely that the delayed cases relate only to the people who completed the course. That would give a very large impact if you completed the course. The cost of the course is put at £300 per participant. I've assumed that to be per person attending the initial assessment and not per person completing the course. That gives a figure of 27 over 53 over 0.53 cases avoided per 1,000 participants. So 27 per 1,000 referrals equates to 50 per 1,000 participants. The program was run online during the epidemic and the costs were presumably lower, but there may not be enough data to make it test whether online courses were as effective as in-person classes. Costs and benefits. Well, as I say, the costs, £159 per referral. The NHS assumed one quality generated for each case delayed or avoided. That seems to me a fairly cautious measure, because what we actually see is that newly diagnosed diabetics seem to lose on average 4.6 life years relative to the healthy population. That's based on incidence figures rather than prevalence figures and survival rates of diabetic patients by age. Anyway, so the one QALY looks cautious, but it's what the NHS have used. The ONS uses a discount rate of 3.5% per annum. So if the quality adjusted life year comes in the future, and I've assumed in 20 years, then discounting implies a current benefit of 30,000 per case delayed or avoided. So with 27 cases of delayed or avoided, you'd get an expected gross benefit of 810,000 for an outlay of 159,000. But there are also savings in treatment costs, and if we set those at £1,000 per annum for 20 years, the discounted sum is 14,600 per patient, giving a further benefit from the 27 cases of 394,000. Now, NHS England have much smaller savings in costs, and I'm not sure of the reasons for those. Anyway, I've worked with total benefits of 1,204,000 per 1,000 referrals. So what's the initial fall in prices? Here I'm moving from looking at 1,000 referrals to 100,000 referrals. The initial size of the program was aimed at 390,000 people. Total health spending £151 billion. A program with 100,000 referrals would raise the cost of that by £15.9 million or 0.01%. So if we look at the ratio of the actual cost to the reservation price, the implied price just before introduction, that gives us 15.9 over 120.4. The change in the log price on introduction is minus 2.02%. The expenditure share is 10 to the minus 4. So if I use the Turnquist formula, the expenditure share is 10 to the minus 4 in the current period, 0 in the previous period. So the change in the log price is 10 to the minus 4, and the change in log of output is therefore the change in the volume expenditure minus the change in the price, and that gives us 2 times 10 to the minus 4, or 2 times 10 to the minus 2%. So that's the basis of my assertion that it doesn't actually have a very large impact. We get a subsequent saving in costs of £2.7 million per annum, or 1.8 times 10 to the 3% of health expenditure. That's a volume adjustment, but as I say, it is money that can be spent on other things, and perhaps we should be looking at a definition of national income net of defensive expenditures like that. But following up the the thread I set up earlier, is the concept of insurable risks clear? Anyway, supposing you do it on the basis of a satellite account approach instead of a national accounts approach, we gained 1350 discounted QALYs. We have to work out the total volume of QALYs generated by medical services. I've assumed half of the QALYs accruing to people aged 65 and over represent the outcome of medical services. I value a year in good health as 1 QALY and a year in poor health at 0.75 QALYs. That's based on surveys of subjective well-being. Well, if you then do the sums, 44.4 million quality adjusted life years were attributable to medical services. So the total increase in QALYs is 3.04 times 10 to the minus 3%. That's an increase in gross output. You need to adjust for the costs to get to an increase in net output. But the point I'd make is that this is smaller than the short-term increase using the new service approach, because the QALY base is so large. And if you think medicine delivers more than 44.4 million QALYs, then of course the percentage increase attributable to the new treatment would be even smaller. So you need to argue that medicine does less than this to get the impact up. So what about conclusions? Well, the striking thing perhaps is how small the numbers are, although with 5.8 million pre-diabetics, you could imagine 1.5 participants in a course adding, say, 0.4% to health service output. And I think expert advice is needed on whether there are more significant preventative programs. To some extent, I've looked under the street lamp. The diabetes prevention program is reasonably well documented. There's the issue that savings on medical treatment don't appear in national accounting welfare indicators, and that raises the question whether we should be looking at alternative measures of national income. Finally, we shouldn't assume that working in terms of QALYs and percentage increases in QALYs will give a larger impact than a more conventional national accounting treatment. So thank you very much. I'll now hand over to Robert.
Yeah, Martin, if I could, yeah, sorry, Martin. No, absolutely fascinating stuff. Thank you very much. And you are a chair's dream, because you're bang on time. So, as you suggested, Martin, over to Robert now to respond. Robert, over to you.
Well, thank you. Let me try and take over the screen sharing here. Let me start by saying why I very much like this paper. If I were to summarize the main goal, and well, I'm sure I'm doing this in a less eloquent way than Martin just did, is really, well, how should we think about better healthcare if we're looking at this as national accountants? And what's helpful here is that Martin had discussed this from various types of better, new treatments, improved treatments, and in particular spending time on prevention, both conceptually and empirically, and indeed sketching a framework that's simple in the sense that it's only looking at at discounted costs and benefits in terms of and where the benefits are longer, healthier lives. Now, of course, that doesn't mean that this is everything we could say about quality, but I think also from a societal perspective, that's the big one. If we're zooming in a little more, what's nice about this paper is that it's it's linking this idea of health outcomes and the quality of outputs. And in that it follows nicely in the tradition of Paul Schreier and others. But also zooming in more on the issue of this timing of benefits and cost and the timing of when better healthcare arrives. So that's how I would give as a pocket summary of what the paper attempts to do. Now, if we're talking about timing, as mentioned, there's two different dimensions, and I think that's where this paper makes a helpful contribution to the discussion. So, if we're talking about benefits and costs, then it's, I would argue you're actually talking about shadow values. The gains in life years versus the discounted cost of current and future treatments. And I would also sort of frame it, compare it a bit to a discussion about investments versus capital services, where a user cost of capital, the rental price, are also, in essence, shadow values of units of capital that are added. The emphasis in the discussion is a lot on reservation prices, and there the idea is that if the service had been available before, it would have been so costly that consumption would have been zero, and through that way track what happens immediately upon introduction to prices, and I think that fits very nicely in recent interest in this, also going back further when thinking about new technologies, new computers or so on entering the market. And I think that reservation price mechanism is a nice way of bringing, of letting us think about in a sense, the quality improvement of healthcare with new or better treatments. A couple of comments then. I think this issue of shadow values versus reservation prices could do with a little clearer exposition. And in particular, in the paper, there's a sentence here saying, the sequence of reservation prices is proportional to the actual cost of the treatment. There is some, and that's I'm not arguing that about that particular way of doing this, but if I'm thinking about neoclassical investment theory and also in the context of healthcare, say a Grossman model of human capital, what is being optimized here? What is is there a social welfare function we're optimizing, and are these shadow values or reservation prices coming out of that? I think being more explicit on this would also helpfully clarify these two elements of the analysis. And maybe I'm being too simplistic here, but I think having a somewhat stylized example, say 3 periods. Say there's period 1, there's no treatment. Period 1, there's a new treatment, and period 2, the patient gets old, and then maybe he only lives to period 3 if they get the new treatment. So there's just to see how this plays out in a toy model rather than with the more abstract discussion now. On the empirical side, I thought this was very nicely executed. So the the table he included gives a very nice summary of, okay, what does this program of prevention for diabetics do? There's also clearly here a net societal benefit. The total discounted benefit of the program is 1.2 million per 1,000 referrals, against a cost per 1,000 referrals of 160,000, so £1 million per 1,000 patients that are referred. So that's wonderful. I would also presume that if you would follow the Cutler et al. Satellite accounts approach, that the implication is that productivity growth is positive. So that's wonderful. And yeah, in essence, then showing how this works through into the national accounts, I think is very sensible. But already once you say, well, the share in total expenditure is T-4, at that point, I think we would have already concluded that you're not going to find massive impacts. And I think the near final slide of Martin saying, well, if we had 1.5 million participants, this would have been quite substantial, is I think a good indication here that nothing against the conceptual approach in this example, but being disappointed by the quantitative impact is, I think, expecting too much from what seems to be a limited scale of the program. So let me stop my screen sharing there and turn it back over to Darren.
Wow. This is good stuff. Thank you both. And you, like I say, I really appreciate you both staying to time as well, but more importantly, providing a brilliant presentation, Martin, and a really, really good response, Robert. Thank you both. So, as I said at the start of the meeting or the webinar, we now have some time for any questions that people would have, and it's a great opportunity to tap into Martin and Robert's brain here about their thoughts. So please do use the Q&A pane if you have any questions that you would like to ask. Hopefully people will be busy typing away. Perhaps just give people a moment, Martin. Martin, I wonder if you've got any thoughts on Robert's response to your presentation. Do you have any immediate reflections?
Well, first of all, could I thank Robert, could I thank you very much for your comments and for the time you put into the paper. Secondly, on the issue of what was being optimized, I rather shortcut that by using a price for a quality adjusted life year. And no, if you use a price for a quality adjusted life year, then I think you don't need to worry about the optimization decisions. Once you've got a price, or a shadow price, it would be more correct to say, once you've got a shadow price for that, you can do the calculations entirely numerically. At least that, I hope that was correct. The issue that Robert referred to, which I didn't bring out in the presentation, is that the Fisher and Scheller argument for new products is that you produce a reservation price. The trouble we face is that the reservation price is in terms of the discounted benefits of treatment relative to the discounted costs of treatment. There's only a single reservation price for that, but it applies into the future if there are future treatment costs. And that was why I had to make the assumption that you change everything in the same proportion. I don't know what Fisher and Schell would say when asked to think about this dynamic problem, but it comes from the fact that there's a single decision while a stream of costs now and in the future.
Thank you, Martin. And Bernard, nice to see you on the call. Thanks for posting the question. Bernard's right. He said we had a lot thrown at us. There's a lot of information, Martin. Is there a paper we can read?
Well, the answer to that is yes. At least I think it's been released on the ESCoE website. So please, if you do want to follow this up, please do look at the ESCoE website. And of course, I'd be very grateful for any comments any of you might have on the paper.
Yeah, thank you, Mike. A good question, Bernard. Thank you to give us the opportunity just to flag that. Let me just see.
I added a link. I mean, I'm not sure whether everybody can see the Q&A, but I added a link to the paper there.
Oh, brilliant. Thank you, Robert. And Sheena, thank you. This is a question I had. I was going to ask, but Sheena's beating me to it, Martin. Have you considered any other preventative programs with the same approach? Do you think this is, approach is applicable to a wider sort of field?
Well, I think the answer is it's probably applicable to a wider field, but if someone, I or the ONS, wanted to take it further, I think the right thing to do now would be to talk to expert medical opinion on which were the programs thought to be most important and therefore most worth looking at, because this sets out a framework. As Robert said, once you see that the expenditure on it is a small fraction of total expenditure, you're not going to get a very big impact. Are there things that other types of preventative treatment which experts think have had a much bigger impact? And obviously, I'm not the best person to ask about this. The diabetes program does have the benefit that it was well documented, but of course there may be other programs that are also well documented. One particular area of interest would be looking at weight loss drugs and the wider the wider use people seem to be making of them. That would be very topical, and if they do a lot to reduce the prevalence of disease, the incidence of diseases associated with being overweight, then they might turn out to have a very large impact using this approach. But I don't, again, picking up on Robert's point, I don't know how total expenditure on those compares with total overall expenditure.
No, thank you, Martin. I can see Ed has. Thank you, Ed. Thanks for the question, Ed. Ed has posted a next question in the pane. Would it be possible to extend this thinking to another similar question? Would it be possible to extend this thinking to another form of preventative treatment, which is defense and its deterrent effect? We don't, however, have a measured and valued quality equivalent, a peace-adjusted life year.
Yes. Well, no, I saw that Ron Smith has signed in. Whenever I talk to Ron about this, he seems to be very doubtful that it could be applied. I think, in particular, to pick up on Ed's point, if you can identify, even approximately the consequences, the societal benefits of various forms of defence spending, then I think it would be possible to apply it. But while we can compare patients referred and those not referred in order to estimate the effects of the programme, I don't think you can do the same with defence expenditure. So it would need, let's say I think it would be probably more speculative than national accountants might feel like incorporating in the national accounts.
No, thank you, Martin. And Marianthi, nice to see you on the call as well. So Marianthi's asked the question about, are there any plans to tie the work back to the quality of inputs? Does the process of adjusting the outputs provide any information on whether the inputs are comprehensive, particularly to align with the sum of cost concept? Good question.
Please, Robert.
Well, one element here is that's I think important for capturing the quality of care is that you want to look at the full chain of treatments, and that well, for diabetics that might be less of a thing, but especially if you have primary care physicians, you have pharmaceutical interventions, you might have operations, and you'd like to look at this as a comprehensive treatment of a condition rather than the traditional way of singling out providers as units of analysis. I think that's where some of this quality should be an important issue.
Thank you, Robert. Prabhat's got a next question about this. There is a set of treatment costs as well as the QALYs that do not arise due to the prevention. Do we have to think about the QALYs that arise from these treatments foregone?
Well, I think what we're doing is looking at a new treatment relative to an old treatment. Now, with the preventative medicine in the diabetic case, I was comparing the outcome with the effects for diabetics who are actually treated using whatever treatments are available at the moment. So I was looking at the QALY gain, or at least using NHS England's estimate of the QALY gain for someone avoiding diabetes relative to someone developing diabetes, and that is based on the treatment, presumably is based on the treatments that are actually available to patients with diabetes and their consequences.
Good stuff. Okay, just seeing, I think at the moment there's no further. Bernard's made the point that it's good on the weight loss drugs and injections. Like you mentioned, you referred to that yourself, Martin. It's very topical, which over the last week or so about preventative medicine. So, as I said at the beginning, this could have far-reaching impacts in terms of implications.
Could I add in one other point?
Of course you can.
No, there might be interest in taking this back a few years to look at the introduction of the COVID vaccine.
Wow.
And the large, what was thought to be quite a large number of lives saved from that. One particular issue you have there with the zero weight in the previous period, though in the previous period COVID didn't exist, so people you couldn't estimate a price people would have been prepared to pay to be protected from it. That's a curious feature of that particular circumstance, but certainly if COVID vaccination were treated in this way, I think you would get a higher figure for the output of the NHS during the epidemic than ONS figures currently show.
Good thought, Martin. Good thought. Okay. My head's starting to hurt, but no, it's good. It's good. I'll think about that. Right. We can see we're heading towards 1 o'clock. So can I just take this opportunity to say thank you to Martin and Robert for such a fascinating session, generally fascinating session. And again, the points that actually at the end has made me think even more of the points you said about COVID as well, and in your response to some of the other questions. Can I thank everybody for attending? We all got busy lives these days, so the fact you've taken an hour to spend some time with us, I'm very grateful. And you will have another opportunity to do so in a couple of weeks. Our next webinar is on the 31st of October between 12 and 1 again. It's called Cheapflation and the Rise of Inflation Inequality. It's going to be presented by Peter Lavelle from the Institute for Fiscal Studies. The discussant is Michael Hardy from the Office for National Statistics. And it's going to be chaired, and you'll be in the very safe hands of Kevin Fox from the University of South Wales and ESCoE as well. So hopefully many of you can make that as well. I think that'll be another fascinating webinar. And can I just say thank you once again to Martin and Robert, and wish you all a good rest of the week and a good weekend when it comes. Thanks very much, everybody.
Thank you.